think everybody is very excited to start this session, so I won't delay any longer. I know more people will be joining, but on behalf of Thrombosis UK, it is an absolute honour to welcome Professor Fionnuala Ni Ainle, who has put together not only an amazing programme for this afternoon's masterclass, but including outstanding VT leads and champions from across the globe to join her. Thank you so much. It's a very special moment also for Thrombosis UK and the Let's Talk Clots conference, because it's the very first masterclass, and what a masterclass this promises to be. VT in gender inclusive women's health. Professor Ni Ainle is a consultant haematologist and full clinical professor at University College Dublin School of Medicine, and serves as clinical lead for National VT Clinical Programme in Ireland. She directs the Irish Network for VT Research and co-directs the Sphere Research Group. She is actively involved in international VT clinical trials and serves on several trial steering committees. Professor Ni Ainle serves as a council member and director at large of the Invent VT, that's the International Network of Venous Thromboembolism Clinical Research Networks. And she has acted as a section coordinator of pregnancy on the task force of the 2019 ESC guidelines on the diagnosis and management of acute pulmonary embolism, and serves on the editorial board of several journals. Furthermore, Fionnuala serves on the council of ISTH class of 2028 and is vice chair for the ISTH Guidelines and Guidance Committee. How you find the time is amazing. A true advocate for advancing understanding and learning in VTE, and a true advocate for patient care. We're honoured to welcome you, Professor Ni Ainle. Thank you so much.
Thank you, Jo, and congratulations on already a very successful week. Thank you for the opportunity to organise this very important masterclass on VTE and gender-inclusive healthcare. And I am thrilled to welcome this stellar world-class faculty of experts from all around the globe. We'll have 5 fantastic talks today. And first, I'd like to welcome Dr. Marc Blondon. Dr. Blondon is an internal medicine and vascular medicine specialist and works in the Division of Angiology and Hemostasis of the Geneva University Hospital in Switzerland. He's also a clinical researcher with a Master of Science Epidemiology from the University of Washington in Seattle. Dr. Blondon's main research and clinical interests are the prevention of venous thromboembolism and women's thrombosis, in particular with regards to hormones and pregnancy. Please put your questions during his talk in the chat box Q&A, and over to you, Dr. Blondon, to discuss VTE risk assessment, postpartum and treatment in pregnancy.
Thanks very much. I'm really thrilled to be here and be part of this Let's Talk Clot initiative. So let me share my screen, which you should see at this time. So I will be discussing postpartum VT risk assessment and a bit on treatment of VT in pregnancy. Really, when we think about VT in pregnancy, the tip of the iceberg are these statistics. I'm going to use this laser. These are great statistics that come from the UK on the causes of maternal mortality. These are contemporary, that's 2018 to 2020. And you can see that still today, thrombosis and thromboembolism remains the most common direct cause of maternal mortality in the UK. This is obviously very rare. It's only 1.4 per 100,000 maternities, but it's still too high, and it's just the tip of the iceberg. What we see regularly are just regular VTs, and that's an example of it. That's a proximal iliac deep vein thrombosis. We know that during pregnancy, the deep vein thrombosis tend to be very proximal, and that can lead to post-thrombotic syndrome, which is an example here below. So that's what we're trying to prevent. The other manifestation is obviously pulmonary embolism, and also we're trying to avoid having to treat VT during pregnancy and the postpartum period because of the burden of anticoagulation, in particular with the peripartum management of anticoagulation. So these are all very good reasons to try to prevent VTE in pregnancy. And when we look at the incidence rate of VTE during the first 3 trimesters of pregnancy, we see there's a gradual increase in the weekly incidence rate. And then what is striking is that the incidence rate really peaks up in the 3 weeks after delivery. And so in terms of prevention, the low-hanging fruit is here. If we want to have the most impact of a short-term prevention, we need to focus our attention to the postpartum VTE in these 3 weeks. So how do we risk assess women after delivery? We're used to doing this for medical inpatients, and we have multiple risk score for that purpose in the UK. You use the UK model, but there's also the improved model, the Padua model. I'm also going to highlight the Geneva model, which is simplified, and this is the simplified Geneva model. And you can appreciate that some of the risk factors will actually apply also to pregnant women, but not all. A personal history of VTE, known thrombophilia, infection, and perhaps reduced mobility may apply to pregnant women, but pregnancy is not a disease. It's just a state in a woman's life. And cancer, cardiac failure, age over 60 years, 60 years definitely don't apply to pregnant women. So we have to think a bit out of the box when we risk assess women after delivery. And I would agree that pregnant women are definitely not classical inpatients. And when we look at the rates of VTE, the risks are much, much lower. On average, we could argue that high-risk medical patients have a 2 to 4% risk of VTE in the 3 months after a medical hospitalization. After a major orthopedic surgery, it's probably close to 3 to 5% without thromboprophylaxis. But on average, antepartum and postpartum women have a much, much lower risk. That's close to 0.1 or 0.2%. So it's a huge difference here. And when we think about postpartum VT prevention, and you have here 1,000 women who have just delivered, it's very hard to identify those two that will end up suffering from VTE within the next 6 weeks to 12 weeks. It's like finding a needle in a haystack. So our challenge is quite difficult here. Furthermore, we're really, really late on the research development in that field. When we compare with medical thromboprophylaxis, already 25 years ago, we had RCTs showing the efficacy of thromboprophylaxis, and that's the MEDANOX trial showing that enoxaparin 40 milligrams was superior to placebo to prevent VTE. And so since then, we've taken the time to develop scores to try to identify who was at risk, who should receive thromboprophylaxis when hospitalized in a medical bed, and then discuss how we would implement this as best as we could. And nowadays, we're already reassessing the efficacy of our treatment 20 or 30 years later, and that's an example of the symptom study that was published this year. So where are we at with VT prevention in pregnancy? Well, we spent quite a bit of effort trying to find the risk factors for VTE, and we've got a huge number of observational studies, usually case control studies, that have highlighted what the risk factors for postpartum and antenatal VTE was. That has kept us busy in the past 20 to 30 years. And we do not have any randomized controlled trial. We have a sequential clinical trial that was published close to 10 years ago now that has suggested that low molecular weight heparin does prevent a VT after delivery, but it's got methodological issues and no report of the bleeding. So I don't think we can actually inform our decision with this unique sequential clinical trial. And we've got multiple guidelines that are expert-based and one score that I'll come back to. So we're really, really late in terms of research development. But what do we know now? I think there are two clear situations. The first clear situation is that a woman who has no or few VTE risk factors after delivery, her average risk is low. I would argue that it's actually below 0.1%, and I don't think anyone would recommend pharmacological thromboprophylaxis for her. Her risk is too low. On the other hand, we have women who hold very strong VTE risk factors. I'll come back to what these are. The average risk is high, and in those, experts and guidelines agree that we would prescribe 6 weeks of low-dose, low molecular weight heparin after delivery. So what's a very strong risk factor? The most striking one is a previous history of VTE. We know that if we don't provide thromboprophylaxis in those women after delivery, about 6 to 8% of these will recur with a DVT or pulmonary embolism within 6 weeks to 3 months. We also know that there are thrombophilia that are at high risk without a personal history of VTE, and that would be antithrombin protein C, protein S deficiency with a family history of VTE, or a homozygous state for factor V Leiden prothrombin mutation, or a double heterozygous states of these two variants. What we don't all agree on is what to do with women who have only one copy of factor V Leiden or the prothrombin mutation, and what to do with people who have a deficit of the inhibitors without a family history. The last ASH recommendation suggests no thromboprophylaxis. The ARCOG UK guidelines from 2015 suggest thromboprophylaxis. I would add one more risk factor that is strong, and that has been highlighted last year in this Danish nationwide cohort study, which has studied what happened to women who have superficial vein thrombosis during pregnancy. So over about 20 years of data from Denmark, they've shown that the risk of superficial vein thrombosis either prenatally or postpartum was quite low, 0.06%. I think that's an underestimate because of the diagnostic scheme that was used based on some coding in the Danish registry. But nevertheless, the most striking data from this study is the fact that these superficial vein thrombosis that were untreated in this study would recur during the pregnancy, either before delivery or after delivery, in about 10% of these women. So that would be enough to actually want to trigger some kind of postpartum thromboprophylaxis. And it also supports the use of anticoagulation, probably at low dose, for pregnancy-related superficial vein thrombosis. That's an example of a superficial vein thrombosis in the great saphenous vein. There's also another vein that's superficial in the leg. That's the short saphenous vein. That's just at the back of the calf. So we're left with 40% of women who have some risk factors, but not the strong ones. And there's clear disagreement on what to do with these women. And if we look at what the guidelines say, and that's work done by a medical student on deliveries in Geneva, you can see that while there's good agreement on whom to give 6 weeks of low molecular weight heparin, these are the high risk. If we apply the UK guidelines, then we would actually provide 40% of women with thromboprophylaxis. And if we apply the North American guidelines, that would be less than 10% because we don't agree what to do with these women. So how do we risk stratify these? We've got knowledge of the risk factors that can be either minor with weak association with postpartum VTE or major with stronger association with postpartum VTE. So the weak risk factors or minor would be an age over 35, a pre-pregnancy obesity, current smoking during pregnancy, a black race, an elective C-section, postpartum hemorrhage, or multiple pregnancy. Examples of major risk factors may be a pre-pregnancy morbid obesity with a BMI over 35, an emergency C-section, an infection at the time of the delivery, any kind of placental disease, and I would group here preeclampsia, growth restriction of the baby, or preterm delivery. And I think one group that has been forgotten from the literature and it's been showing up now is the high rate of postpartum VTE among women who deliver a stillbirth. And I think we should not forget that these women may deserve thromboprophylaxis. The question is how to group these risk factors, and there's really two ways to do so. The first one is what we're probably most used to do it, is applying the ARCOG or a similar scheme, saying that we need probably a couple of minor risk factors, or at least one major risk factor to trigger 10 days of low molecular weight heparin, or at least a few days of low molecular weight heparin. But another way to think is try to get an individual risk estimate of the postpartum VT in each woman. And we've got a model to do so now, which is called a maternity clot risk model. It's been developed in the UK, it's been externally validated in Sweden, and again, externally validated on other data in the UK. And you can appreciate that it contains all the risk factors we would expect, like eclampsia, smoking, postpartum hemorrhage, parity, age of delivery, BMI, the baby's birth weight, and the mode of delivery. There are some caveats here. This should not be applied to any women with thrombophilia, and there's possible methodological bias in that the populations in which this model was developed and validated had some kind of thromboprophylaxis for a proportion of it. And so the actual predicted probability might not be totally right. The second question is, what do we do with an individual risk estimate? In other words, is there a threshold of VT risk to prescribe postpartum thromboprophylaxis? If we ask the experts, and these might be guideline experts, they would say that about 1 to 3% risk of VT after delivery is sufficient to trigger postpartum thromboprophylaxis. If we look at the guidelines, and in particular the UK ARCOG guidelines, then we think it's closer to 0.2 to 0.5% risk of VT, so quite different. And obviously the number needed to treat will be different. If we assume a 70% risk reduction with low molecular weight heparin, the number needed to treat to prevent one thrombosis goes from 50 to 700. But I guess one of the major player here is the women themselves. What do they think about that? And that's work we've done in Paris and Geneva in the last couple of years. We've done interviews of 122 pregnant and postpartum women, and using a discrete choice experiment, we estimated the preference for either a short-term low molecular weight heparin or no treatment after delivery based on differences in VT risk and bleeding risk. We assume again an efficacy of low molecular weight heparin of 70%. And we were quite surprised. The women actually value very much postpartum thromboprophylaxis. And you can see that at a risk of 0.1% of postpartum VT, most women would actually prefer short-term low molecular weight heparin to no treatment, despite a fairly high number needed to treat to prevent one thrombosis. This number remained small at 0.2%, even when we added 1% increase in major bleeding. And I just added the subgroup of the antepartum interview and postpartum interview, showing you that it did not vary depending on whether the one woman was actually in the postpartum period or in the antepartum period. So what have we learned so far? We've learned that VT has a high burden during pregnancy. We have identified individual risk factors. We know how to identify women at very low risk and at very high risks. And we know that women value postpartum thromboprophylaxis if it works. What we need to understand is how to actually mix those risk factors together to better risk stratify the intermediate risk stratum. And I guess the most important is we have to show that thromboprophylaxis is effective and safe after delivery. And really today we're in a world of hope-based VT prevention after delivery, and we'd like to move to an evidence-based VT prevention, just like we did in medicine about 20 years ago. When we look at the data currently, this systematic review published this year in Obstetrics and Gynecology informed us that there's insufficient evidence to guide decisions for postpartum thromboprophylaxis. We only have 4 pilot trials, 2 more are going to come, but they're not going to be able to actually change our evidence towards safety or efficacy of heparin. And we can think about harm based on postpartum low molecular weight heparin, secondary postpartum hemorrhage, non-obstetrical bleeding, wound complications. These are not high harm, otherwise we would sense them in clinical practice, but remember that we're trying to prevent something that's quite rare, so even a rare harm might have relevance. And here I want to highlight two efforts that are ongoing. The first effort is the PARTM study led by Leslie Skeith, who's going to talk right after me, who's trying to assess the efficiency of aspirin for 6 weeks after delivery, which has the benefit of being an oral drug, and has finished her pilot trial. And hopefully this will follow up as a full study to provide answers for aspirin as thromboprophylaxis. The other effort we're trying to launch from Geneva is a randomized trial of short-term low molecular weight heparin in this intermediate risk women compared with no treatment in an open label fashion. And that's something we're looking for fund currently. So what should we do now? Very easily, high-risk women use 6 weeks of low molecular weight heparin, and that should be a fairly universal decision. Low-risk women, just clinical surveillance and no pharmacological thromboprophylaxis. The question is what to do with the 40% that are left, the intermediate risk women. And I think we have to decide to use either a national or make up hospital guidelines based on local preferences. And remember that the views of women are actually quite individual. Some women, on average, they value very much thromboprophylaxis, but some women value it more than other. And I think it's a good decision to make with a shared decision-making process. I'll just finish quickly with the VT treatment in pregnancy, which is a few words on a few topics. I'm obviously not going to go into details. What do we have in terms of anticoagulation in pregnancy? We're left with not much because fondaparinux is pretty much a last resort. We should not use it unless we don't have any alternatives because it does cross the placenta. It's found in fetal blood. Vitamin K antagonists should be avoided because of the embryopathy that they have a consequence of, the bleeding risk at delivery, and perhaps a high risk of miscarriage. One specific group of women in whom VK might be of interest is the women with mechanical heart valve, but these are very specific women. And we don't have much data on direct oral anticoagulants, but we know that they cross the placenta based on placental model. There's placental and fetal toxicity when used in animals at a very high dose, a higher dose than when we use for VT treatment. We have few human data, no strong signal for harm, but not enough data to be reassuring. So we should not use them at this stage. So we're left with therapeutic low molecular weight heparin. Gladly, they work and they're fairly safe. This is a meta-analysis that's already a few years old, but it's shown that when used at the therapeutic dose, the rate of antenatal bleeding and postnatal bleeding is low, below 2%, and the rate of recurrent VT in those treated for an acute VT was low as well, around 2%. Another good news is that there is, I would say, almost no, probably no heparin-induced thrombocytopenia in pregnant women treated with heparin. One of the questions that comes up regularly is whether we should adjust dosing based on anti-10A levels. And I want to refer you to this nice paper by the King's College in Circulation 2013 that has shown that the metabolism of, that was enoxaparin at the time, varied quite majorly in pregnant and non-pregnant women. And in pregnancy, you have a greater clearance, but also a greater volume of distribution. And that will actually increase the half-life, decrease the peak levels, that's what we tend to see during pregnancy, but increase the trough levels. So definitely, we should not rely on our usual levels for anti-10A in women. And as we don't know much how to do else, we should probably avoid at all doing anti-10A monitoring in women who are treated with therapeutic low molecular weight heparin during pregnancy. And most recommendations would say just do a once daily or twice daily weight-based low molecular weight heparin without any monitoring of the dose, except perhaps in women with extreme weights. The other point I want to make is with regard to pregnancy-related pulmonary embolism. Is don't forget risk stratification. We're used to doing it in non-pregnant populations. Here we have a fourth player, apart from hemodynamic status, the size of the ventricle, the cardiac biomarkers. We also have the fetal status. That can be a sign of insufficiency. If the woman is deemed at low risk, then it would be simple low molecular weight heparin. If it's an intermediate risk, then we should probably not, in pregnant women, be more aggressive than when we should. So it would be plain anticoagulation with either heparin, IV heparin or low molecular weight heparin, and have a close surveillance of both the mom and the fetus. And what's probably most dramatic is when we face a woman with a high risk pulmonary embolism, so massive pulmonary embolism. These women should be filled, but very cautiously with volume, also have adrenergic support, and a very close obstetrical surveillance on top of the usual hemodynamic surveillance. We don't have much data to inform how to do recanalization of the pulmonary arteries, but what we've shown in a meta-analysis a few years ago is that thrombolysis as a first line in the antepartum and late postpartum period seemed fairly safe and fairly efficient. What we've shown, however, is that the risk of postpartum hemorrhage in the first 2 to 3 weeks after delivery was really, really high, close to 60% in women who receive thrombolysis. So in these women, for instance, women who have a massive P after a C-section, we probably have to consider other alternatives than thrombolysis, perhaps ECMO, surgical embolectomy, or catheter-directed thrombectomy. And if we don't have the expertise for these locally, then probably go with thrombolysis, but be prepared to have to fight against a major bleed. So I'll stop here, and I just want to sum up on postpartum VT prevention. It's a huge decision. It's 5 million births in Europe every year, so every 6 seconds we have to take that decision. And you've seen the dramatic divergence of guidelines for the intermediate risk woman. For the time, we should implement what we think is best and assess. And I think it's time to improve the evidence to inform future pregnancy. And if you're interested in joining this effort, you can contact Leslie Skeith or myself for research projects. Thank you very much.
Thank you so much, Professor Blondon, for an absolutely stunning talk. And you highlight the importance of this question and the huge knowledge gap. And we have a few questions, but can I just ask you, given that we have had national guidelines now in the absence of high quality evidence for many, many years, can you maybe comment on the challenges that we may face, that you and Dr. Skeith may face in rolling these trials out internationally, or do you have hope?
Well, I have a lot of hope. There are many barriers. One of them come from the fact that we've highlighted that VT in pregnancy is very important. What we often forget is that it's very seldom. It's infrequent compared to what we usually see in our other patients. And so there is a belief that VT prevention should be almost universal in some centers. So we have those kind of barriers that can exist for research from a research perspective. But I'm very hopeful that we'll manage to get answers.
Good. Congratulations to both of you and your leadership. A few questions. I think you addressed this already, but is fondaparinux safe in pregnancy and breastfeeding? Maybe particularly highlighting when low molecular weight heparin is contraindicated.
So fondaparinux does cross a bit the placenta. So we would only use it if the woman cannot be treated with a low molecular weight heparin, and that can be the case in terms when there's, for instance, an allergic problem. But we tend not to use it as long as we don't have to.
Thank you. And would you recommend anti-10A monitoring with low molecular heparin? I know you dealt with this as well, but in particular scenarios in pregnancy and postpartum. Maybe if we could recap on that question.
Yeah, so I would probably in two kinds of women. The first is the extreme weight. If you have a woman that's very heavy, and that's over 100 or 150 kilograms, you may want to know where you're exactly at. But yeah, I would not only monitor the peak level, but also the trough level. And obviously women that have a low renal clearance that gets to be close to 30 milliliter per minute, then in those women, you want to make sure that you're not too high.
Okay. Thank you so much, Professor Blondon.
Thanks.
So Moving on now to Dr. Leslie Skeith. Dr. Skeith is an associate professor and hematologist at the University of Calgary, Canada. She is a global international leader in clinical trials in this area, and Dr. Skeith's clinical and research interest is in the area of pregnancy, hormones, and venous thromboembolism. And today, Dr. Skeith will be considering VTE in people receiving hormonal therapy. Thank you, Dr. Skeith.
Thank you for inviting me to speak today. Let's bring up my slides here. All right. Thank you for the invitation. I'll speak about VTE in people receiving hormone therapy. And if you think of this very broad topic, there are many indications for hormonal therapies, from contraceptive therapy, replacement for deficiencies such as for menopause, gender-affirming hormone therapy, and others. And I will spend some time as a brief overview talking about the first three. I will present some data relating to transgender and gender diverse individuals. But before I do, it is nice to put into context some of the data from contraceptive, HRT in cisgender, menopause women, so you can extrapolate and look through the data. So we do know that estrogen does impact the coagulation system by increasing procoagulant markers, decreasing anticoagulant markers. It does depend on the dose, the formulation, the structure. And we do know that progestogens do impact or potentiate estrogen's impact. So it is a combination of the type of estrogen, the type of progestogen. And just one note on testosterone is that we do see changes on coagulation, but this is more at supraphysiologic doses, at least in the lab, and we'll briefly touch on testosterone as well. So I borrowed this very helpful slide from Shannon Bates, who presented at ISTH last year, 2022, and who had a nice breakdown of contraceptive therapy. So we'll start here with cisgender individuals. This is either combined with estrogen and progestin of either oral COC or non-oral options, or progestin-only options. And at least in Canada, we now have a third oral option, drospirenone, over the last 3-4 years, as well as non-oral options such as the IUD or intrauterine system, implant, and the injection, the Depo-Provera. And just when I say progestogen, this is a broad category to cover both physiologic progesterone and synthetic progestin. Lots of big words in this talk here. So with our contraceptive therapy, the initial VTE risk, I think before I go through some of the numbers, important to keep track that this is really a lower risk population at baseline in 2 unexposed cohorts, not exposed to COC. It was 1.9 and 3.7 per 10,000 patient year risk of VTE without any hormone. So overall, we're talking about a low risk group. And with that initial VTE risk, with that initial exposure with combined oral contraceptives, the relative risk is around 3.5. But when you talk to a patient, talking in relative risks can be quite challenging. Unfortunately, this is a lot of the literature in hormones are talking about relative risks and how you put that into absolute terms. There was a nice study that did highlight the absolute risk depending on the different hormones, and it's in the range of 6 to 11 per 10,000 exposure years. So in the big picture, the risk is increased, but to an acceptable amount for the majority of individuals, especially without other risk factors. It does depend on the estrogen dose. We initially had, our first generation ethylene estradiols were in the 50 micrograms. They were higher doses. On average now, it's 30 to 40 micrograms, and now even seeing 20 to 30. So we are having less risk with more recent lower doses. And it also depends on the progestin. The levonorgestrel does have a lower risk than others consistently in the literature. And we have to think about these added risk factors when approaching different patients. There's a really helpful systematic review published in JTH in 2016 that highlighted that all thrombophilias do increase that risk. In particular, it's the natural, the more strong or natural deficiencies, antithrombin, protein C, protein S deficiency, where we really should be avoiding the COC use if possible. More of a discussion, I think, for the mild thrombophilias or for other risk factors, and what to do with combinations of risk factors. I think we still have very little data on. What would we look to avoid thrombotic risk? We have our different progestin-only contraception with our oral with low dose for contraception, or our IUD or intrauterine system has no increased risk of thrombosis. I want to highlight 2 cohort studies. If we're using progestin at higher doses for bleeding management, it actually does carry a risk. Maybe this is also highlighting the type of patient, someone who's older, maybe it's a different population as well, but there is a higher risk for progestin-only pills used at higher doses. And we do have little data for the injectable DMPA, but it does may have a modest risk, so I do avoid this. So just to highlight that not all progestin-only contraception are equal. There's very little data for the subdermal implant. This is new for us in Canada. We have one study where we can exclude risk. It'd be interesting to hear what others in Europe and the UK think of this relating to risk. But in my practice, I would typically suggest a progestin-only IUD if possible, or having the low dose oral option as alternatives. But there's risk benefits in other domains for these. What about risk of recurrent VTE after a contraceptive associated VTE? There's debate in the literature whether this is unprovoked, major provoked, or a minor provoking risk factor with hormones. We looked at a meta-analysis with 19 prospective studies, including getting additional data, unpublished data from many of the papers. And the bottom line, I think, is overall, it is low risk of recurrence after stopping the hormones at 1.22 per 100 patient years after a contraceptive associated VTE, after stopping anticoagulation. I think our challenge is that sometimes there is that higher risk group where we don't know, what to do. Someone with added risk factors, maybe they've been on hormones for 10 years and there's something new or different. I think this group does warrant further review and further research. We had with Marc, Rodger, Gregoire, Legal, and others as part of the reverse cohort evaluated COC users versus non-users as part of validation of the HER2 score. So this is a post hoc analysis breaking down the HER2 score between COC users and non-users. And here is the score. Age greater than 65 is less relevant, but elevated BMI, D-dimer using the VIDAS greater than 250, or leg symptoms with an assessment at 6 months had with a low score of 0 to 1 and 2 or more being a high score. So already we see that the COC users had a lower percent per patient year, 1.1%, compared to an otherwise unprovoked group at 3.2%. But when you start to dive into the scores, it also spreads out quite nicely that those with a higher score with a COC user had 3.5% compared to a 6.1% for a non-user. So I think overall these numbers, are generally low, but is, helpful for discussion, helpful to think about these other risk factors in addition to hormones to help guide decision-making. Again, post hoc subgroup analysis more for future research and discussion. We do have evidence that you can safely continue hormones while on anticoagulation. And if you are thinking of stopping anticoagulation, we do know that there is an increased VTE recurrent rate by around 4.6-fold in one study when continuing hormones. So recommending if you stop hormones to stop stop anticoagulation to stop hormones, from a nice study from Marc Blondon called the Pill Off study, presented at ISTH this year. The hemostatic changes resolve around 2 to 4 weeks for the majority of patients after hormones are stopped. And that, as I mentioned earlier, progestin-only contraception is not associated with recurrent thrombosis, first-time or recurrent thrombosis from the data that we have. Most studied are the oral or the IUD, progestin-only IUD. So moving on to our hormone replacement therapy for cisgender individuals, it gets a bit more complicated. There are more options, especially for the progestogens. I think, bigger take home is that you can have both transdermal route or oral route for the estrogens, and you only need to use estrogens if somebody has had a hysterectomy. But for kind of cancer protection, if there's an intact uterus, to also add progestogens, which are primarily oral, micronized progesterone, or the pregnane or non-pregnane derivatives. Lots of options, things to read around. The baseline population risk for hormone replacement therapy, I think we also have to keep in mind that it is higher. It is not the 2 to 3 per 10,000. In one unexposed cohort, this was 16 per 10,000 patient years. And while HRT carries a lower relative VTE risk compared to contraceptives, around that 1 to 2, 1.5 to 2.3, the absolute risk may be higher because we're starting at that higher baseline risk, or at least the same or higher. And it also does depend on whether it's estrogen alone or combined with progestogens. And very reassuring for first-time initial VTE risk with transdermal, with the estrogen or combined HRT. And that micronized, if you had to choose different or recommend different progestins, the micronized progesterone or the most pregnane progesterones do not appear to increase thrombotic risk compared to the others. What about recurrent VTE risk? We're kind of diving into, I would say, less and less data, but we have an excellent randomized controlled trial evaluating oral estradiol and progesterone versus placebo in postmenopausal women with prior confirmed VTE. And just to get a breakdown of who these, there were 140 women who these were, majority were unprovoked VTE, but there was also a higher number of provoked VTE. You can see the breakdown here. They stopped the trial early due to an excess VTE events in the HRT arm, with 10.7% versus 2.3% in the hormone replacement versus placebo arm. So really to highlight that there is this risk here. This is the Kaplan-Meier plot, and this is similar findings in a WHI RCT as well. I think what is really interesting, but we also have very little data, is in the transdermal estrogen group after a prior VTE. We have one cohort study of over 1,000 postmenopausal women with prior VTE, and they compared users versus non-users. This was, again, not randomized. They used adjusted analyses. 22.4% had prior unprovoked VTE, just for interest. And they also saw the same signal for oral estrogens, with an adjusted hazard ratio of 7.2, but there was no added signal for transdermal estrogen, but with wider confidence intervals, smaller numbers. I think we just have to be aware of the limited data, but overall looking, reassuring that it does not increase the risk of thrombosis. In a nice review, this is also highlighting the same thing. We have 3 studies, 2 randomized trials, 1 cohort showing the risk of recurrent thrombosis with oral estrogens for replacement therapy versus transdermal. Looks okay, but limited data. So we'll move on to our transgender, gender diverse, or TGD individuals, and just some definitions to get everyone on the same page. A transgender woman is somebody who is assigned male at birth, who's taking feminized or could take feminizing hormone therapy, who would identify as a female or a woman. This is estrogens and anti-androgens, and I'll go through that. Progestins may be added on an individual basis, but are not recommended in guidelines, but are often used after, case by case. Transgender men are individuals assigned female at birth who identify as male and would potentially take masculinizing hormone therapy or really different formulations of testosterone. I think something that maybe we don't always appreciate is that there also may be combined estrogen progestins or progestin-only options also for menstrual suppression and or contraception in some individuals. So here are different breakdowns, and it gets a bit more complicated because it could be estrogen alone, combination of estrogen and anti-androgen, possibly progestogens. Overall, the estrogens are the 17-beta estradiol, either in oral or non-oral form, or different parenteral options, the estradiol valerate, which is not available at the United States. It is in Canada. Sorry, I don't know in the UK what is available. And ethylene estradiol and conjugated equine estrogens are no longer recommended as part of the guidelines, which I'll go through in a little bit. Anti-androgens could be spironolactone or cyproterenone acetate. And the second does have significant progestogen activity as well as an anti-androgen effect. I think I covered everything here. I think some caution to the literature, which I'll cover on broad strokes, is that they're mainly retrospective cohorts that report on hormone therapy in TGD individuals, and thrombosis usually is not the only focus. And because of that, most studies did not standardize VTE rates to person years of follow-up. And that's a big limitation when trying to compare across studies. It's usually reporting one DVT in an individual out of a group of individuals without knowing that context of the follow-up and duration. And we often can't compare one agent or one drug formulation directly. So for example, there's one cohort in the United States that had 17-beta estradiol and spironolactone as the anti-androgen, and how to compare that against a European cohort that's using estradiol valerate and cyproterone acetate can be quite challenging. And then anyway, we will leave it at that. It is challenging to review. We do have a recent systematic review of 22 studies. The initial VTE risk in transgender women is around 42.8 per 10,000 patient years, and in transgender men, 10.2 per 10,000 patient years. You can imagine a variety of different treatments, durations. And overall, transgender women had higher thrombotic risk compared to cisgender women or cisgender men when matched to risk factors or prior thrombotic events. And they also included cardiovascular prior thrombotic events. I would say, overall, this is a similar or higher risk. I would compare, someone more similar to someone who's cisgender women using HRT, kind of the same or higher risk than that. The hormone type matters. In earlier studies, starting in 1975, the most common regimen was ethylene estradiol 100 micrograms per day and cyproterone acetate 100 milligrams, and they found they had a high VTE rate. Again, 19 patients out of 303, so 6.3% risk of VTE. And in a longer kind of duration from 1975 to 1994, an annual incidence of 0.4%, 2.6% in the first year of initiation, mainly in those oral with oral agents. And what happened based on this early publication in the Netherlands with this large clinic is that there was a major change in practice around 1989, where transdermal estrogens were now being recommended to those greater than 40 years old. We don't have a clear pre and post study, but it does look like the incidence has dropped down. And just to maybe put it into perspective, our current oral ethylene estradiol for the COC is 30 to 40 or 20 to 30 micrograms per day. And our current use of the, and we no longer, ethylene estradiol is no longer recommended in the transgender population, and the cyproterone acetate, the average dose is starting dose is 12.5 milligrams every other day or every day, up, maybe up to 25 to maybe up to 50, but not up to 100. So we are seeing big differences. In another study, more recent study looking at an oral 17-beta estradiol with spironolactone that is not thought to have an increased thrombotic risk. This is in the range of 7.8 per 10,000 patient years, or one patient who had a thrombotic event. So you do get a sense that things have decreased. And the same, in similar to HRT for cisgender individuals, that transdermal estrogens carry no or a small number of ET events reported in the transgender, gender diverse population, keeping in mind that there's also usually an anti-androgen in the background. So hard to know if that small number is related to the estrogen or the anti-androgen. The literature is very sparse relating to inherited thrombophilia and other risk factors. There was one study that screened, it seemed like consecutively, for thrombophilia in 251 individuals. The majority that were positive, probably not surprisingly, was factor V Leiden. I think this was in Australia. There were no patients who developed thrombosis. And the guidelines do say, and there are different guidelines recommending against screening for inherited thrombophilia prior to hormone initiation in most cases. And there's very little data for other risk factors, but seems to be similar to those in cisgender women. What do the guidelines say? Probably the biggest guideline for transgender health was published in 2022, recommending transdermal estrogen for eligible transgender and gender diverse people at higher risk of developing VTE. They do use the age greater than 45 or previous history of VTE, and something similar from the Endocrine Society in 2017, as well as the addition of an injectable estradiol as well. So just to think about the formulation, the dose, especially focusing on transdermal estrogens for those at risk. So I think practical guidance is to use the lowest effective hormone dose, consider transdermal estradiol for those with risk factors. Something that comes up often is around surgery, either relating to gender surgery or other surgery, and not to stop the hormones, but to consider thromboprophylaxis at higher risk times instead. Similar to what I would advocate for a cisgender individual as well. And management of hormone-associated VTE is extrapolated from our other studies, but it is to continue hormones as long as someone is anticoagulated. I'd like to highlight the North American Thrombosis Forum has a toolkit for transgender health and blood clots. And I think this is all in the website, but the key thing is to take away from all of these resources is that the risk for blood clots is not and should not be a barrier to gender affirming care and hormone therapy. And they have videos, a toolkit, a really good resource as a place to start. My one obligatory slide on testosterone. There are mixed results from large observational studies ranging from no risk up to a fourfold risk, with a follow-up meta-analysis of 13 randomized trials and over 5,000 patients with a varying control arm showing no increased risk of VTE, with the caveat that they termed the quality of evidence to be low. This was a similar signal for cardiovascular events that flagged Health Canada and the FDA, but as subsequent meta-analyses, there have been two, have found no increase in risk for thrombosis. And this is mainly from the cisgender population and a lot of extrapolation in the transgender men. So I just want to highlight, I was trying to reflect on different cases that I've seen over the last few months. 51-year-old cisgender woman with prior major provoked DVT after surgery wants to use hormone replacement therapy. A 28-year-old transgender woman on an oral 17-beta estradiol who developed an upper extremity DVT and was found to have thoracic outlet syndrome. And a 16-year-old I saw who is a transgender man considering IVF to harvest and store embryos prior to initiating testosterone, with a family history of VTE and thrombophilia, which is also a murky area. I think all cases to highlight the limited data, the importance of shared decision-making and incorporating patient values and preferences. So what did I do? Not to say it's right or wrong, but to highlight the possibility of the transdermal option. But I did review the very limited evidence in this scenario, trying other non-hormone forms, gathering more information, but possibility of the transdermal option. But interesting to hear what others would say. For the person who has a thoracic outlet syndrome, upper extremity DVT, I did put in a surgery consultation with an overall joint decision for no surgery and continuing on a low dose DOAC, as she was also continuing on hormones. With the goal, we reduced to the lowest, and this was in consultation with her endocrinologist, to the lowest possible transdermal dose. And based on side effects and patient preference and big decision making, eventually stopped anticoagulation altogether and has been doing well without recurrence. And our patient considering IVF with a family history of VTE and thrombophilia had a risk-benefit discussion about the thrombophilia testing, which they decided to do to have further guidance relating to thromboprophylaxis during IVF. So I'd like to highlight and a big acknowledgement and thank you to Dr. Shannon Bates, hematologist, thrombosis expert in McMaster, for use of slides and additional guidance, and Dr. Sad, an endocrinologist and gender-affirming hormone therapy expert in Calgary, who I email and ask a lot of questions to. Thank you very much.
Thank you, Dr. Skeith. That was a really, really elegant talk, and thank you for the gender inclusivity of your talks always, and your considerations for various scenarios. There are some very nice questions in the Q&A, which I will go through now if we have some time. What is the approach for people who are on hormonal therapy or HRT and undergoing major surgery? Do you ask them to stop the hormone therapy 4 weeks prior to surgery, or do they continue with risk assessments?
I would, there's very little data in this area, but I would favor the second or the latter approach. I think what is practically challenging for someone who's on hormones, who may be on for different reasons, is that 2 to 4 weeks later they may have a bleed, have a menstrual cycle, or during recovery after surgery it's otherwise quite stable otherwise. So I would recommend continuing, but to add, the Caprini score has hormones as a risk factor. If you use a risk score, to consider thromboprophylaxis around that higher risk time in hospital or after, depending on the surgery, for any, I think, scenario of the hormones.
Thank you, Dr. Skeith. So the next question is, what is the maximum dose of transdermal estrogen that can be used in people with a history of VTE?
I have to say, I don't know that. I often would ask, and I wouldn't be the one prescribing the transdermal, it is a good question, and whether I can look back in the paper to see what the dose was. I don't know.
And I think it highlights the need for further evidence as well, doesn't it?
I think so. I think it is still a very uncertain area. Whether we use this or not is uncertain. So it does. Thank you.
Yeah. Can I ask, Dr. Skeith, in Canada, are there national guidelines surrounding the use of hormonal therapy in people looking to use HRT who have had previous VTE? Do you have national guidelines? Yeah.
Don't believe we do. No, I don't think so. And it's hard with that, just that one study too. That's right.
A comment, very, very nice actually, would be helpful to have a summary of hormonal therapy types and medications and VTE risk to aid discussion and decision. And I know there are definitely some very nice patient information aids, aren't there, Dr. Skeith, on the Thrombosis UK website?
Yeah, excellent point. And bringing some of these numbers together with a number of people, or in Thrombosis Canada, I think we have a thermometer of risk with the pregnancy risk and the with the excellent point, having those discussions with decision aids.
Excellent. Thank you so much, Dr. Skeith. We just, in the interest of time, we'll move on. And now it's my great pleasure to introduce Professor Ilia Robert-Ebadi. Dr. Robert-Ebadi is a board certified in internal medicine and angiology. She's responsible for the angiology unit and the division of angiology and hemostasis of Geneva University Hospitals in Switzerland. Her main field of research is clinical research in VTE, with a particular interest in the diagnosis of pulmonary embolism and DVT, but also other aspects of management of people with VTE. And she's currently co-chair of the ISTH Scientific and Standardization Committee on Predictive and Diagnostic Variables in Thrombotic Disease. Her talk today will focus on VTE diagnosis during pregnancy. Thank you, Dr. Robert-Ebadi.
Thank you very much, Professor Ni Ainle, for your invitation. And it's a pleasure for me to talk to you today about the diagnosis of VTE during pregnancy. So the plan is to start by getting a general overview of current diagnostic strategies for VTE in the general population, and then discuss the challenges that we meet in the diagnostic management of pregnant women with suspected VTE, and finally go through the available data, including recently published management outcome studies in the field of PE diagnosis and their impact on clinical practice. As you all know, the main problem that we have, be it outside or during pregnancy, is that clinical symptoms and signs of DVT and PE are most often non-specific. So diagnostic algorithms have been developed over the last 3 decades, and they're based on the sequential assessment of clinical probability, D-dimer level measurement, and investigations with imaging tests when needed. The concept of pretest clinical probability, and as I took here as an example the Wells score for DVT, is to assess the presence of factors associated with the presence of the disease, and then adding up these points gives you a final score, which is basically associated with the prevalence of the disease. And you can see here the typical figures of prevalence in the low PTP categories, intermediate PTP categories, and high PTP categories. In this setting, D-dimer is used as an exclusion test because of the high sensitivity of these tests. When it is applied in patients with a non-high clinical probability, so a low prevalence of the disease, then they have a high negative predictive value of almost 100%. So in patients with a clinical probability which is assessed as being low intermediate using a 3-level score or unlikely using a 2-level score, negative D-dimer allow excluding the disease without any further investigations. What can we use as a safe threshold for PE diagnostic strategies? As you know, the historical invasive tests such as angiography or phlebography are no longer performed because of the complications associated with these tests. We do not have accuracy studies, but rather management outcome studies. And here you have a communication from the SSC of the ISTH published in 2017, which says that the safety of diagnostic strategy in VTE is assessed by the rate of VTE events occurring during the 3 months following exclusion of the diagnosis by the strategy, which is also called the failure rate of the strategy. And a strategy is deemed to safely exclude VTE if the 3-month VTE risk is below 2%, in line with the historical invasive tests as pulmonary angiography and venous phlebography. The safety of excluding VTE by high sensitivity D-dimer assays have been widely demonstrated. And here in one slide, you can see the 3-month VTE risk, which is very low after a normal D-dimer test, as shown by this systematic review by Marc Carrier, with a 0.14% VTE risk during the 3 months after a normal D-dimer test. So in these patients, the diagnosis can be safely excluded. And in terms of usefulness of this, what we know is that the diagnosis can be safely excluded in 1 out of 3 outpatients without any additional testing using D-dimer. So it's only in patients with a high or likely pretest clinical probability or a positive D-dimer test that investigations are needed, only 2/3 of patients. In terms of imaging tests, what we know outside pregnancy is that CTPA has now become the imaging of first choice in the setting of PE suspicion, and the safety of excluding PE by a CTPA has also been demonstrated. Here you see the results of a systematic review and meta-analysis using such strategies with a pooled 3-month VTE incidence of 1.2%. The problem which has raised over the following years is the wide availability of CTPA and its overuse. So over the last years, the strategies now tend to focus on increasing the diagnostic yield or efficiency of D-dimer in order to reduce CTPA use. This is a busy slide, but just to say that 2 main strategies have been assessed. Here you have conventional strategies on the first line using PTP, D-dimer cutoff of 500 in all patients. And you can see that approximately 1/4 to 1/3 of patients can have the diagnosis excluded with conventional strategies. The strategies to increase the yield are basically the age-adjusted strategy and clinical probability adapted cutoffs to increase D-dimer yield. So the age-adjusted cutoff is based on a cutoff of 500 up to 50 years, and then age per 10 in patients over 50 years old. And the clinical probability adapted cutoffs have been studied in the YEARS study and the PEGD study, basically using the same principle of using a higher D-dimer cutoff of 1,000 micrograms per liter if the PTP is low or no YEARS item is present here. And then using a conventional 500 micrograms per liter threshold, so the standard threshold, if the PTP is not low. And you can see here the yield of PTP and D-dimer in these studies, so the percentage of patients managed without imaging. But these figures should also be put into the perspective of PE prevalence, which varied widely between these studies. So a strategy using a high threshold of 1,000 in a population of patients with a low prevalence of PE as low as 7% may not be as safe if applied to this population with a risk of false negative results. So why do we use D-dimer then outside pregnancy? If we start with 100 patients with a clinical suspicion of PE and apply PTP assessment and D-dimer measurement, what we see is that we can exclude the diagnosis based only on these 2 simple tests in 35% of the patients. And here I use the numbers from the Adjust PE study for these figures. So only 2/3 of patients will need imaging and CTPA, and in the end, confirm 20 PEs, so 3 CTPAs to diagnose 1 PE. The problem that we have is that all these adjusted cutoffs in these large studies and also clinical probability cutoffs, well pregnant women were excluded from these studies. And so what challenges do we face in pregnant women? The first and not the smallest challenge is, when should I suspect VTE in a pregnant woman? What we know is that clinical assessment is particularly difficult in this setting, as 50% of pregnant women report having some degree of dyspnea, and we also know that approximately 50% of women have lower limb edema. There's also the atypical presentation of iliac DVTs that we see during pregnancy, presenting as lower back pain or sciatic-like pain, which can be a clinical challenge. Nevertheless, obtaining a diagnosis with the highest level of certainty is essential in this population of young women, not only because of the risks and complications associated with anticoagulant treatment, but also because this diagnosis can have an impact on future lifelong decisions, as was demonstrated earlier by the 2 previous talks regarding decisions on oral contraceptive prescription, the management of future pregnancies, and later in life, the prescription of hormone replacement therapy in the oral form at least. And what we know is that PE remains the leading cause of maternal mortality in Western countries, and Dr. Blondon showed in one of his slides recent figures for PE being one of the most frequent direct causes of maternal mortality, even though the figures are low, but still, among other causes, it remains one of the most important causes in the UK. So the fear of missing a PE diagnosis and its potential fatal issue during pregnancy leads to a low threshold for suspecting DVT and PE in pregnant women. And this is well reflected by the prevalence of confirmed disease, which is even lower here than in the general population. You can see that the percentage of pregnant women with suspected DVT having the diagnosis confirmed is only 10% compared to 30% in the general population. And in PE, figures are even lower based on the most recent trials that I will show to you later during this talk. 2 to 7% of all suspicions have PE confirmed compared to 10 to 20% in the general population. The problem that we have with usual diagnostic algorithms are mainly concerns about maternal and fetal radiation, pregnant patients having been excluded from the large VTE diagnostic studies, and so pregnancy-specific prospective data remained very scarce until recently. The problems are at each step of the standard diagnostic algorithms. First of all, there is no available CPR, which was developed until recently for pregnant women to select patients at lowest prevalence of the disease for safe exclusion of the diagnosis by D-dimer. Second, regarding the D-dimer, there is a reluctancy to use D-dimer during pregnancy because of concerns about safety based on limited prospective data and no CPR to select patients, as I said before. Also around usefulness, as D-dimer levels are known to increase during pregnancy. And finally, even more than outside pregnancy, there is a willingness to minimize radiating tests in these young women. So now let's go through what available data we have for DVT and PE diagnosis during pregnancy. Starting with the diagnosis of DVT during pregnancy, an important information which has been known for a long time already is that 80% of DVTs during pregnancy occur in the left lower limb. Here you have the derivation of the left score, which is a clinical probability assessment score of DVT during pregnancy, developed by Chan and colleagues, published in 2009. And 3 items are assessed here: symptoms in the left leg, an objective confirmation of lower limb edema with a 2 centimeters or more circumference difference between the 2 cuffs, and the presentation during the first trimester of pregnancy. And you can see, according to the number of items present in the left score, increasing DVT prevalence from 0 to 16 to 58%. This was a cross-sectional study in 5 Canadian tertiary centers at the beginning of the years 2000, and you can see here the prevalence of confirmed DVT of 9%. Regarding lower limb compression ultrasound, the prospective validation study during pregnancy and postpartum was the EDWICH study, led by Professor Legal and colleagues and published in 2012. 226 patients were eligible and suspected with deep vein thrombosis. 210 with suspected deep vein thrombosis, in whom a complete whole leg lower limb compression ultrasound was performed. And you can see here the prevalence of DVT, again, 10% in this study, and patients who had a negative compression ultrasound and were left untreated, therefore, during the follow-up, had a very low risk of 3-month VT at 1.1%. You can see here the upper limit of the 95% confidence interval, which is rather high at 4%, but this is related to the limited sample size of this study. Again, an interesting observation here is that 80% of the thrombosis diagnosed were in the left leg. Another interesting information that we can find in the EDWICH study is regarding the presentation and the trimester of pregnancy. You can see here that the majority of women with suspected PE were during the 3rd trimester of their pregnancy. But if you look at the prevalence of the disease among suspected patients, you can see that when you suspect DVT during the first trimester of a pregnancy, the chances that you actually find a DVT are much higher, with a prevalence of 20% among suspected ladies in this group. The integrative diagnostic algorithm using the left rule D-dimer and complete lower limb compression ultrasound is ongoing now. It's a prospective multinational study called the LEAD study. And if you are interested by more details around this study, you can find the clinical trials identifier here. What do we know about D-dimer during pregnancy? Well, what we already know is that blood coagulation parameters change a lot as pregnancy advances. And basically, there is more thrombin generation and less clot dissolution as the pregnancy advances toward the third trimester. Physicians are not always willing to use D-dimers, and what refrains them actually to use D-dimers to exclude VTE during pregnancy? There are three main arguments which are brought, and I will talk about these in a few minutes in more detail. One of them is that there is no PTP score that I can use to identify patients at the lowest risk and be quite confident in my negative D-dimer in terms of negative predictive value. The second one, and the most frequent, is that it's useless to use D-dimer during pregnancy because all pregnant women have increased D-dimer levels anyways. And the third one is that maybe D-dimer is not even safe because as we saw that fibrinolytic activity is decreased, how can I be sure that there's no clot based only on low D-dimer levels? So if we start with the pre-test clinical probability assessment of PE during pregnancy, we did not have any pregnancy adapted score up to recently, so we tried based on the results of the CTPE pregnancy study that I will present to you in more details in the last part of my talk. We tried to adapt this Geneva score to pregnancy. Basically, what we did is to eliminate from the score the two items which were absent in this population of patients, so the age of more than 65 years and the presence of active malignancy, which were found in none of the pregnant women with suspected PE. And then for the continuous variables, we ran ROC curves and tried to identify the most discriminative threshold, which was found to be at 40 years of age and 110 beats per minute. What we saw here is that the PAG score allowed to stratify patients into three categories of pretest clinical probability corresponding to expected prevalences of the disease of less than 10% in the low PTP, more than 50% in the high PTP, and between 10 and 50% in the intermediate PTP categories. In terms of performance, you can see here the ROC curve with an AUC of 0.8. The second point which was raised is that D-dimer levels increase during physiological pregnancy, and so many people tend not to use them, saying that they will be positive anyway. And indeed, D-dimer levels increase during physiological pregnancy, something which has been shown more than 20 years ago on samples from 144 women during pregnancy. But if we look at these from a diagnostic perspective and we set the threshold at 500 micrograms per liter, what we can see here is that the majority of women are indeed above the threshold, but there is a significant number of women during the two first trimesters of pregnancy which could have negative D-dimers if we look at it from a diagnostic perspective. This was also confirmed in a more recent work in an Irish center with another D-dimer test. And again, looking at these from a diagnostic perspective with a threshold of 224 nanograms per mil, which was the threshold used by the test that was used in the center. Again, a non-negligible proportion of pregnant women can have negative D-dimers in terms of diagnosis during pregnancy and up to 20 weeks of gestation. Guidelines remain controversial regarding the use of D-dimer in this setting, and here it was a review of all guidelines up to 2017 for the moment. And what you can see is that some societies advocated for the use of D-dimer, some against the use of D-dimer with grade D, class D levels of recommendation, and some societies did not take any position or no recommendation. But if we do not use PTP and D-dimer, and we start again with 100 pregnant, this time pregnant women with suspected PE, what does that mean? That means that we need to do imaging in all in order in the end to find 7 PEs. So more than 14 CTPAs to diagnose 1 PE. And this is a very high number needed to test, considering that this is a young population of pregnant women. And as I think Professor Skeith or Blondon said before, this is not a disease, but it's a physiological state. So we would like to minimize radiating tests even more than in the general population here. When it comes to imaging, other debates that rise is what imaging to use in suspected PE during pregnancy, lung scintigraphy or CTPA. And the main considerations raised by this systematic review are radiation exposure to fetus and the mother, and especially breast tissue. What we know is that CTPA is more radiating for the mother's breasts than lung scintigraphy, and it goes the other way around when regarding fetal radiation. Availability of the test is obviously an issue, as you know that many nuclear medicine centers are not open 24 hours a day and 7 days a week, so that can be complicated in terms of accessibility to imaging. There's also some considerations regarding interpretation and final diagnostic conclusions. CTPA gives you a yes/no answer, whereas scintigraphy is usually reported as likelihood ratios, which can be more complex to be integrated for a clinician. Local expertise obviously plays a role in selecting the imaging modality, depending on what expertise you have in your center. And finally, another consideration was the rates of inconclusive tests, a rather high level of CTPAs being inconclusive, 12% reported here, but we will see that in the more recent studies, this is much lower than the numbers reported here. 14% for VQ scans, so significant but much lower in the general population, because these young women usually do not have comorbid cardiopulmonary conditions. The estimated radiation absorbed in these procedures used for the diagnosis of PE are reported here in terms of fetal and maternal radiation, and I don't think it's interesting to get into details of these numbers, but the message is that all these figures are well below what is considered a dangerous threshold for the fetus or for the mother. Guidelines on which imaging modality to use, and again, this is was published in 2017. You can see here in blue the nuclear medicine imaging, in orange CTPA, and these guidelines vary widely. And for the nuclear medicine imaging, you can see that some societies advocated for perfusion scan only, and others for VQ scan, and the data were very limited for any of these recommendations. What we look forward to see in the future is the results of a prospective observational cohort assessing the quality and safety on optimized CTPA protocol in pregnancy in order to reduce maternal radiation. And this is the Optica study led by Professor Ni Ainle and colleagues. And this basically uses CTPA protocol parameters and settings adapted for pregnancy, and also a scan range which is more limited. And the aim is to not only assess the quality of these tests, but also the safety. And we very much look forward to the results of the Optica study. Imaging for suspected PE, much debate, but there's one general consensus, and this is that the risks of undiagnosed PE or inappropriate anticoagulation by far outweigh any risk from any diagnostic imaging tests. Now, briefly, in the last minutes of this talk, the 2 recent prospective management outcome studies in pregnant women with suspected PE. The first one, the CTP pregnancy study led by Professor Regini in the Geneva group, based on the assessment of a pre-test clinical probability using the revised Geneva score. That's what we had. And as I said before, 2 items are non-relevant to this population, but that's the score that we had at that time. D-dimer testing, then bilateral lower limb CUS in all patients, followed by CTPA when needed. Second one, the Artemis study. This is a pregnancy-adapted years algorithm, starting by the assessment of 3 items: clinical signs of DVT, hemoptysis, and PE as the most likely diagnosis. All patients with the clinical signs of DVT had a compression ultrasonography of the symptomatic leg. And if there was no DVT, or if there was no years item, the higher threshold of 1,000 was used, as in the original years study, and a standard cutoff of 500 in patients with 1 or more items present. What has been commented on this study is that the D-dimers were ordered at the timing of the assessment of years criteria, so they may have influenced this subjective item of PE as the most likely diagnosis. Results in terms of safety of these 2 strategies were similar, a very high level of safety with 0% and 0.2% 3-month VTE risk following a negative strategy. And you can see here variations in the PE prevalence, 7% in the CTP pregnancy study, 4% in the Artemis study. In terms of the diagnostic yield of the different tests used, what you can see here is that we had 12% of negative D-dimers using a 500 standard cutoff. When CUS was done in all patients systematically, only 2% had DVT confirmed, and altogether 14% of pregnant women could be managed without chest imaging. In the Artemis study, you can see that hemoptysis is extremely rare in this population. 9% of pregnant women with suspected PE had signs of DVT, and when you perform CUS in these, you have 7% of positive tests. So something suggesting that maybe we should keep CUS only for patients with symptoms in the leg when they have suspected PE. Confirmed PE 4%, and patients with negative D-dimer as per this algorithm 39%. Trying to perform an external validation of this pregnancy-adapted years model to our CTP pregnancy population, no safety issues with 0% PE at initial testing or during follow-up in patients with a negative algorithm. What we can see, nevertheless, is that 25% only of patients were classified as having no years criteria versus half of patients in the Artemis study, and the efficiency of 21% compared to 39% in the original study. Taking all the results of these 2 prospective studies and 2 older studies, we performed a meta-analysis on the D-dimer for exclusion of VTE during pregnancy, showing a very high sensitivity and negative predictive value, an efficiency of 34%. So how does this all translate into clinical practice? If we take again our 100 ladies with clinical suspicion of PE and perform now PTP assessment and D-dimer, we can exclude 34 diagnoses based simply on these blood tests, and imaging is needed in 2/3, confirming PE in 5. So you can visually already see here a much lower number of imaging tests to diagnose 1 PE during pregnancy. And given the low prevalence of confirmed VT among suspected women, all safe strategies minimizing radiation tests are welcome. Recommendations advocate for D-dimer measurement and CPR use, and perfusion scintigraphy or CTPA as the imaging modality. So in summary, clinical assessment is particularly challenging during pregnancy. Prospective data remained scarce until recently, but you can see that the field is actively evolving. We need prospective validation of the PACS score before we can use it in clinical practice. Adapted D-dimer cutoffs may be considered. And now we also saw that higher quality evidence is available for CTPA than for VQ, and we look forward to low-dose CTPA protocols. And I thank you very much for your attention.
Thank you, Professor Robert-Ebadi, for that absolute tour de force of such an important area. So thank you. And there is one question, but I think you actually answered it in the second half of your talk, which was your beautiful review on CTPA versus perfusion imaging. And I think it's so interesting how the field has moved forward in the past couple of years. Can I ask Professor Robert-Ebadi, just while we're waiting for more questions, your pregnancy adapted Geneva score is incredibly interesting. Congratulations on deriving and validating this score. Have you any plans, Dr. Robert-Ebadi, to perform a prospective clinical management study to look at this in more detail?
Yeah, sure. So that was just only the first step. And because of the low numbers of PEs, we had 395 patients in the CTP pregnancy study and 28 events. So we could not really do a proper multivariable study. So that was the suggestion of a score. So definitely it needs external validation. If we can do so in the Artemis cohort, that's a plan that we have for the near future.
Wonderful.
And obviously prospective validation, which is under construction.
Oh, that's great news. Congratulations. It's such a big thing to put together. And
thank you very much.
Can you remind me, what was the cutoff for the pregnancy adapted Geneva score? What is the score that is the cutoff below which you do not suggest doing a CT?
Actually, it's for the assessment of PTP, and then we do D-dimer anyways.
Okay, fine.
Yeah.
Thank you so much. And a nice comment in the chat saying thank you very much for the presentation.
Thanks a lot.
Merci.
Thanks. Merci beaucoup. Thank you.
So without further ado, we'll move on to Dr. Barry Kevane. So it's my pleasure to introduce Dr. Kevane, who is a consultant hematologist with a specialist interest in thrombosis and hemostasis, and is based at the Mater Misericordia University Hospital in Dublin, Ireland, and the Ireland East Hospital Group. Dr. Kevane is also a principal investigator with the UCD Conway Sphere Research Group, and his main area of research interests are in translational and clinical studies in thrombosis. His talk today is looking at syndemics in gender-inclusive female health. Thank you so much, Dr. Kevane. Over to you.
Good afternoon, everyone, and thank you for the introduction and for the invitation to present in this forum today. So over the next few minutes, I'd like to give a brief overview of our current understanding relating to the effect of socioeconomic factors on VTE risk, and how applying a syndemics framework may represent a new way of thinking about the intersection of poverty, homelessness, and VTE, as well as the role of gender issues and potentially exacerbating vulnerability in this context. So in my practice in Dublin, we serve a very diverse urban population, and our catchment area takes in some of the most disadvantaged communities in Ireland. But I think regardless of where we live or work or the types of patients that we see, I think most of us would agree that health and illness are not equally distributed across society, and that poor health disproportionately affects poor people. However, it's important that we also recognize that how we think about disease etiology in the context of socioeconomic disadvantage is really central to our ability to effectively develop and deliver equitable health services. And this is because we are often guilty of thinking about diseases in isolation and attributing health outcomes to individual factors or individual risks or individual risk behaviors alone or individual choices. In contrast, the syndemic framework seeks to understand health and disease in a broader social context, recognizing that it is often macro level social, political, and economic factors which actually determine our ability to achieve good health and our health chances. And health chances are defined by the World Health Organization as the cumulative exposures of a lifetime, which determine our overall health profile. And of course, some of this, of course, relates to genetic or inherited traits. But in reality, much of our ability to achieve health during our lives is actually determined by external social factors, such as our ability to access healthcare, housing, nutrition, and education. And the social determinants of health are the conditions in which we are born, grow, work, live, and age, and the inequities in power, money, and resources which give rise to the conditions of daily life. It's well accepted that poverty is a major determinant of lifelong health outcomes. People who live in the poorest communities not only spend more of their lives living with poor health and disability, but also die at younger ages than their counterparts in higher socioeconomic groups. And this is true across all gradients of socioeconomic status. And so syndemic theory is rooted in the belief that many diseases move along specific fault lines in society, disproportionately affecting people who are poor, people who are experiencing homelessness, and people who are subjected to gender and race-based marginalization, among other vulnerable populations. And a syndemic is defined as when two or more diseases or health conditions cluster in a single vulnerable population, where these diseases or health conditions interact with each other and the broader social context or the social circumstances of the individual to lead to further adverse health outcomes and an increased burden of ill health overall. And some of the social, political, and economic factors which drive the emergence of syndemic conditions include not just economic or financial marginalizations, but also factors like racism, and particularly structural racism, as well as the effect of social and cultural norms on marginalized groups. Syndemic theory first emerged in the 1990s when it was used to study and explain why surges of HIV continue to be observed among disadvantaged minority groups in the United States. The first syndemic that was described was the SAVA syndemic, consisting of substance abuse, violence, and AIDS. And this was characterized by the clustering of these conditions in poor Black communities that had been made vulnerable by decades of racism and structural violence, which were negatively impacting on health behaviors and on the ability of these individuals to access health services. More recently, of course, the COVID-19 pandemic has also been described by some as a syndemic because the spread of SARS-CoV-2 was particularly rampant among poorer social groups who are clustered with other diseases driven by socioeconomic disadvantage, including cardiovascular disease, with the interaction between COVID and cardiometabolic diseases in poorer social groups being associated with some of the worst outcomes which were observed during the pandemic. And so the use of the syndemic model has increased in public health research over the last 2 decades because studying health and disease in this broader context allows us to develop strategies for recognizing how social, political, and economic factors can perpetuate ill health and also helps us to identify targets for multi-level intervention. And while most of syndemic literature relates to infectious diseases or cardiometabolic diseases, I think it is also worth thinking about VTE in this context, also given recent data demonstrating a link between socioeconomic status and VTE risk. And these reports include this study from Dr. Haley Jorgensen and colleagues from Norway and Denmark, which examined the incidence of VTE in large Danish population registries using indicators of socioeconomic status, which included level of education, income, and employment. And they found that for each of these parameters, as well as for a composite of all 3 indicators, that the risk of incident VTE was lower in people with higher levels of socioeconomic status. Other reports using similar indicators of socioeconomic status in large population-based studies have reported similar results, where people achieving higher levels of socioeconomic status have lower rates of incident VTE. Unfortunately, as well as being at higher risk of VTE, patients with low socioeconomic status also appear to have or may have inferior outcomes following VTE and potentially are even treated differently by healthcare providers. Data from both these large US-based retrospective studies, incorporating data from Medicare and nationwide inpatient samples databases, suggest that patients from low socioeconomic groups are less likely to be offered advanced therapies for high-risk pulmonary embolism and have higher one-year all-cause mortality rates. And in both these cohorts, there seem to be a predominance of females and people from ethnic or racial minorities in the lower socioeconomic group. And several other smaller studies have also reported similar observations, with poorer patients less likely to receive specialist follow-up, less likely to be offered DOACs or thermoprophylaxis in the setting of cancer, and more likely to have worse survival at 3 months, 1 year, and 5 years. And among survivors of VTE, Scandinavian registry data suggests that patients from lower socioeconomic groups are more likely to experience permanent work-related disability following VTE, thereby risking exclusion from the labour market and further socioeconomic adversity. The burden of health inequality faced by disadvantaged groups is, of course, proportionate to how severely disadvantaged they are. And the term social exclusion has been coined to describe perhaps the most severe form of poverty, deprivation, or marginalization, which is seen in middle to high income countries. And this term is usually used in reference to people who are experiencing homelessness or people experiencing deprivation in association with substance misuse disorders, as well as other marginalized groups, including prisoners, sex workers, and other ethnic and gender minorities. And for the rest of this presentation, I will focus primarily on the socially excluded population. So social exclusion, as I've said, is the most severe form of socioeconomic disadvantage that's observed in middle to high income countries. But socially excluded people are often so marginalized that they're almost invisible to healthcare providers, policymakers, and researchers. Social exclusion is usually defined as the inability of an individual to participate in the normal social, political, and economic activities of life due to the effect of intersecting adverse biological, psychological, and social factors, including severe poverty and marginalization. And for overlapping populations who experience severe social exclusion are people experiencing homelessness, people with substance misuse disorders, prisoners, and sex workers. And in studies of social exclusion, virtually all individuals report a history of traumatic childhood experiences and marked socioeconomic deprivation from birth. It's important to note that gender appears to be a major determinant of adverse outcomes among socially excluded and homeless people, with evidence of particularly marked vulnerability to ill health among women who are experiencing social exclusion, as well as other gender minorities. So the burden of morbidity and mortality in the setting of social exclusion is extreme, particularly among the homeless. The all-cause standardized mortality ratio for men experiencing social exclusion has been reported as 7.89. However, this is even higher among females, suggesting an increased vulnerability among women to the health effects of social exclusion. In a recent Irish Health Research Board report, we saw for the first time data describing mortality patterns among people who died while experiencing homelessness in Ireland. The median age of death among males was 40.5 years and 39.5 years among women. It's well known that women do not experience homelessness in the same way as men and usually present with a different pattern of contributory factors, and in particular higher rates of mental health issues and adverse childhood and family experiences. And in these data, 75% of homeless women who died while homeless had a history of a mental health issue, in contrast to 29% of men. And interestingly, while drug poisoning or suicide accounted for the majority of deaths in both genders, cardiovascular disease accounted for about 20% of all deaths, despite the young age profile. Given our interest in social exclusion as a severe form of socioeconomic disadvantage, we've also recently sought to evaluate VTE risk among this subgroup of disadvantaged people. In this analysis, using data sets obtained from the Irish HYPE system, which reports data on all hospital admissions episodes in the Republic of Ireland. And in this study, we looked at all such episodes occurring over a consecutive 12-month period. And in the analysis, we used indicators of severe socioeconomic disadvantage to try to identify people who were likely to be experiencing social exclusion. And during the study period, there were 5,700 admission episodes where a VTE diagnosis was attached to the patient record, of which almost 5% were in individuals where there was at least one concurrent indicator of social exclusion also recorded. And in comparison to the inpatient population as a whole, people with any indicator of social exclusion present had a significantly higher odds of having a concurrent VTE diagnosis attached to their record. And data relating to outcomes among this subgroup of disadvantaged individuals, the socially excluded group, are somewhat lacking. But in our own experience, in our institution in inner city Dublin, which, as I said, serves a very diverse urban population, about 20 to 25% of all referrals to our thrombosis clinic relate to people who are socially excluded, primarily people who are homeless or people who are engaging in injecting drug use. And our experiences, and I'm sure this mirrors many other urban institutions, has been that the delivery of care is extremely challenging, particularly in the setting of homelessness and injecting drug use, where there are high rates of recurrent VTE, poor adherence to treatment, and many of these patients are either lost to follow-up or never attend at all, and so they are grossly underserved and undertreated by current healthcare models. And of course, these data raise the question as to why is VTE risk even increased in this setting? So data describing mechanistic links between socioeconomic status and venous thrombosis are sparse, but there are likely, or there may be, some parallels with other vascular diseases, including cardiovascular disease, where very clear links between social factors and disease risk have been described. So in that setting, complex interactions between factors relating to health literacy and health behaviours appear to be crucial. But in addition, fascinating observations have recently been made relating to neurobiological changes associated with the chronic psychological stress of poverty. And these stress-related physiological responses, which are termed the allostatic load, represent the cumulative physiological damage which arises secondary to cognitive or emotional responses mediated by the hypothalamic pituitary adrenal axis, which in this setting, in the setting of severe deprivation, is characterized by inflammation and even cardiac events, as illustrated by these investigators in these data recently published in JACC, demonstrating links between socioeconomic status, chronic psychological stress, and physiological damage as evidenced by neurocognitive responses, arterial inflammation, and even perhaps the risk of major adverse cardiac events. And recently, a meta-analysis has shown a relationship between adverse childhood experiences, and particular severe childhood deprivation, and elevated inflammatory markers in adulthood, clustering alongside cardiometabolic diseases. Of course, the degree to which we can extrapolate these observations to venous thrombosis is theoretical at present, but the hypothesis that poverty and severe deprivation may themselves mediate a pro-inflammatory state is interesting when we consider what we now understand about the relationship between inflammation, thrombosis, and vascular disease. But of course, there are also many other perhaps more obvious risk factors for thrombosis in the setting of a social exclusion, such as injecting drug use, which I will also discuss shortly. So if all these data suggest that socioeconomic factors may contribute to thrombosis risk, this then begs the question if are there vulnerable social groups where thrombosis may represent a syndemic condition which interacts with other health conditions and the social status of the individual to worsen outcomes. And just to recap, for a syndemic to exist, there must be a vulnerable population that has been subjected to socioeconomic deprivation, where that deprivation then leads to multiple health conditions emerging, and where these conditions interact with each other and the social context, either through biological, psychological, or social pathways, to worsen the overall burden of ill health. Although men comprise the majority of socially excluded people, socially excluded females present with a different pattern of contributory factors and a different pattern of vulnerabilities, alongside gender-specific factors which may interact, influencing health outcomes further. And across all the literature describing homelessness among women and gender minorities, including trans women and trans men, there is almost a universal history of traumatic life experiences, stigmatization, and economic as well as gender-based marginalization, which are deeply rooted in the social context and which drive the spiral into homelessness, and then in particular into substance use disorders and mental illness. And the intersection between poverty, racism, and gender-based oppression has already actually been identified as a driver of a syndemic of mental illness and substance misuse among women from poor backgrounds. While thrombosis has not really been considered in these syndemic models to date, we do of course know that injecting drug use, which of itself is a global epidemic, is a risk factor for thrombosis, which is highly prevalent among socially excluded and homeless populations of all genders. For example, in Dublin, it's been reported that up to 70% of our homeless population have engaged in injecting drug use. So the injection of drugs such as heroin or crack cocaine into the groin or femoral veins in particular is a major source of thrombosis risk in this population, as well as a source of other health complications such as infections and sepsis. And over 50% of people who inject drugs eventually resort to injecting into the groin veins. And a very recent systematic review and meta-analysis has estimated the prevalence of VTE among people who inject drugs at approximately 29%, with an annual incidence of TVT in this group, which is far in excess of the general population. There is some evidence to suggest that the risk of VTE related to injecting drug use is particularly marked among women and sex workers for reasons that are not entirely clear, but which may relate to specific patterns of drug use and in particular in relation to the use of stimulant drugs like crack cocaine, which are highly irritant to the vascular wall. And in urban areas, of course, this is a huge problem, with one report from Scotland estimating that in over 50% of cases of isolated DVT in women under 40, that injecting drug use was implicated as a causative factor. As I mentioned earlier, in a true syndemic, the illnesses which emerge interact with the social circumstances of the affected person to further worsen health outcomes. And this is certainly a potential feature of VTE among the female socially excluded or homeless population. There are obviously huge implications here for pregnancy and reproductive health with regards to thrombosis risk and the management of anticoagulation. It's been reported that at any one time, up to 13% of homeless women may be pregnant, which is far in excess of the general population. Most of these pregnancies are unintended, but contraceptive use is low among homeless women due to issues around accessibility, cost, and lack of counselling. Access to abortion, of course, is of direct relevance to maternal health. And researchers from a large US-based abortion service provider reported recently that up to 19% of terminations performed in their centre were for homeless women, but that due to barriers which these women faced in terms of confirming a pregnancy and accessing services, these women were more likely to present at later gestations and therefore were potentially exposed to additional risks, particularly in the setting of prior VTE or VTE management. Socially excluded women are also, of course, at risk of abnormal uterine bleeding when treated with anticoagulants, but these women are more vulnerable to the financial burden of trying to access menstrual hygiene products and period poverty, as well as also being exposed to the additional risks of bleeding associated with physical violence or traumatic injury, which they're potentially more often exposed. Members of the transgender community and other gender minorities have other risks associated with poverty and homelessness, which may interact with VTE risk, including the vital need for gender-affirming hormonal therapy, which in the setting of poverty or homelessness is often obtained illicitly without prescription or medical supervision. And it's important to note that members of the transgender community are overrepresented in the homeless populations. And so the cycle of social exclusion, VTE, and addiction disorders are driven by large-scale social factors, which I think we will all probably agree that they are. This means that they may represent a syndemic, and therefore we should think also about the provision of care from a syndemic perspective and look not just at the disease in isolation, but at the broader social circumstances of the individual when trying to deliver care. Because providing care to this patient group can be extremely challenging, and we must be conscious of the barriers which they face when planning care provision. The cognitive burden of poverty refers to the degree to which the daily experience of severe deprivation markedly affects patterns of cognition, making it difficult for patients to prioritize their own health or to even wish to engage with health services of whom they are often quite distrustful. This can be further compounded by other more obvious barriers to care, including issues around being able to obtain transportation to clinic appointments, or even the ability to receive written notice of clinic appointments when staying in unstable housing or when living on the streets, as well as internalized barriers which they face, which are often rooted in the shame and stigmatization of homelessness, which leads to negative thoughts about their own health prospects and a reluctance to engage with healthcare providers. Interactions between socially excluded people and healthcare providers can often be challenging and frustrating on both sides, particularly in the setting of addiction and perceived threatening behaviours or perceived drug-seeking behaviours. And repetitive patterns of negative interactions between patients and healthcare providers have been described, which probably stem from a lack of understanding of the complex psychosocial state associated with social exclusion. And this has been described recently in an Irish publication led by Dr. Austin O'Carroll, who is a leader in the provision of primary care services to homeless and socially excluded in Dublin. And of course, in the thrombosis clinic, we need to recognise that it is unrealistic to expect that the same model of care that works for housed, wealthy, well-educated people will work for people whose daily lived experience is characterized by the lack of shelter, hunger, and addiction. And we need to design services which meet people where they are, and not necessarily where we think they should be, even if this means that we aren't always able to do things perfectly or completely by the book. And it's important that we consider the potential for morbidity in this group, particularly where we may have issues around poor adherence to therapy and the risk of recurrent VTE, particularly in the setting of persistent or ongoing injecting drug use. As I've mentioned at the start, these patients are often excluded from clinical research, so it is really hard to formulate evidence-based guidelines around the optimal management of VTE in this setting. And so it's really important to make individualized treatment decisions which take into account the very specific recurrence and bleeding risks which pertain to this group of disadvantaged or these vulnerable populations. And when developing healthcare services for this patient group, we must ensure that these services engage with the patient's ability to perceive, their ability to seek, reach, pay, and if applicable, to pay for services. And in some scenarios, this may mean designing services where there are shared care models with drug treatment, addiction centres, etc., focusing on, I guess, trying to optimize care pathways, even if these may not necessarily be hospital or clinic based. And from a macro level, advocacy for policy changes which prioritise affordable housing, education and healthcare access are really crucial in protecting future generations from continuing to experience the same cycle of poverty. And as healthcare researchers, we must consider how we can avoid the current model where these patient groups are largely excluded from clinical and translational research. So in conclusion, socioeconomic status is a major determinant of health and contributes to thrombosis and vascular risk. Social exclusion is a severe form of socioeconomic disadvantage, which is associated with very poor health outcomes, particularly among women. Injecting drug use, mental health issues, poverty and thrombosis may represent an emerging syndemic, particularly among women where the intersection with gender-based health issues represents an additional potential source of health risk and poor health outcomes. Providing equitable healthcare is incredibly challenging in this setting, requiring multi-level interventions and an approach to the patient which is informed by a knowledge of the social context of the illness, not just the illness in isolation, recognizing that macro-level social, political and economic factors often give rise to and perpetuate disease risk in this context. So thank you very much for your attention, and I'd be happy to take questions if there is time. Thank you.
Thank you so much, Dr. Kevane. That was an incredibly powerful talk and beautifully delivered. Very, very nice comment there from one of our attendees. This is a thought-provoking presentation, very well presented. And I'd actually like to pick up on that because just as we are waiting for further questions, you pose a very interesting and challenging hypothesis, which is that this represents a potential syndemic. And if that's the case, this is a real call to action. So how do we move forward as a thrombosis community, but also as an international healthcare community?
Thanks. So I think there's probably two things to look at in that setting. It's the provision of clinical care and then the issues around including these individuals in clinical research going forward. So I think from the clinical perspective, I think one of the challenges is we need to move away from the idea that current care models are suitable for this population, and we need to recognize that we need to design things differently in order to meet the needs of these vulnerable patients. And in some scenarios, like I alluded to, and something which we are trying to do locally in Dublin, is to try to engage with the drug addiction treatment centres in the community, where some of these individuals will often have very good relationships with their key workers or with stakeholders locally, and almost providing a sort of remote care pathway, because and that kind of takes advantage of the existing relationships and doesn't place additional strain or additional requirements on these individuals in their attempt to access care from hospital-based services. And from the point of view then of, I think, as a community and looking to the future, I think looking at perhaps being slightly more flexible in how we approach research is the only way we would ever be able to adequately bring these patients along with us, because I think that sometimes the rigidity of the protocols, which obviously are required in order to undertake high quality research, are difficult to apply when maybe there may be issues around follow-up or attendance from these patients. So it's hugely challenging, but I think it's about being flexible in our thought and in our way of thinking around how we deliver care, and thinking more from the perspective of the social context of the disease rather than the disease itself.
Thank you. And thank you, Dr. Adamczyk, for the very nice comment. I agree. There were a few points that you mentioned that I think were fascinating from a potentially mechanistic perspective. So you touched on, early inflammaging and the very exciting area that is inflammaging, but why did I pick you up right? Why the increase in VTE risk in persons who inject drugs, in female persons who inject drugs compared to male? Do we know, or is it just an observation at this point?
It is just an observation at this point. I think and I have to say, as I've sort of alluded to, the quality of research is low for obvious reasons across this entire area. So that all of these, I suppose, observations come with that caveat. But one of the hypotheses behind that potentially higher rate among women has been due to patterns of drug use among sex workers, and in particular the use of stimulant drugs among sex workers, where drugs like crack cocaine are more widely used and are more irritant to the vascular wall than the injection of opiates. So that's a theory, but as I said, there are huge gaps in our understanding around this.
Okay, well, look, thank you so much, Dr. Kevane, for your own leadership in that area. And in the interest of time, we'll move on, but thank you.
Thank you.
So now it's a huge honor to welcome Professor Marc Rodger. Dr. Rodger is the chair of the McGill University Department of Medicine and physician-in-chief at McGill University Health Centre, and the Harry Webster Thorpe Professor of Medicine. Dr. Rodger's teaching, clinical care and research focuses on venous thrombosis. He co-founded the Canadian Institute of Health Research funded CAN Vector Network, and also is past chair and current volunteer executive director of INVENT, which we spoke about before, the International Network of VTE Research Networks. We are absolutely delighted to welcome Marc and to learn more about the role of academic clinical trial research networks in supporting clinical trials in women's health. What does the future hold? Thank you, Professor Rodger.
Thank you. Thanks, Professor Ni Ainle and Joe Jerome and the Thrombosis UK family for the opportunity to present today. I'm just going to make sure that my slides are sharing properly. Okay, can you confirm that you can see my slides?
Yes, thank you, Dr. Rodger.
Okay, great, thanks. So yeah, it's my pleasure to talk to you about academic clinical trial research networks in supporting women's health and what the future holds. But before speaking about the future, I'd like to speak a bit about the past and perhaps tell you about a cautionary tale. So I did research in the late 1990s when I was completing my master's in clinical epidemiology and thrombosis fellowship training. I became interested in the placenta-mediated pregnancy complications, which include late pregnancy loss, intrauterine growth restriction, preeclampsia, and placental abruption. And these were the leading causes of maternal, fetal, neonatal morbidity and mortality in developed nations, and there were a poverty of effective interventions to prevent their recurrence. And this area really got started in 1999 when Michael Kupfermink published a case control study that demonstrated an association between the placenta-mediated pregnancy complications and thrombophilia, with an odds ratio of 8 in those that had a placenta-mediated pregnancy complications harboring a thrombophilia compared to controls. However, association is not causation, and certainly association shouldn't lead to therapeutic decision-making or preventative prophylaxis of thrombophilias. So one might wonder what the link might be here. There may be a link between thrombosis in the placenta and these placenta-mediated pregnancy complications. And this potential link might lead us to believe that a therapeutic intervention like low molecular weight heparin anticoagulants might prevent these complications. And indeed, based on these association studies, many latched onto this and prescribed low molecular weight heparin. And for over 15 years, low molecular weight heparin use was prevalent to prevent these placenta-mediated pregnancy complications. And at the extremes, as an example, in Argentina, it was in fact the law that if a woman had a placenta-mediated pregnancy complication, they should be thrombophilia tested, and if they had a thrombophilia, they should be offered low molecular weight heparin. So I just leave this slide up just for a second to absorb the impact of daily self-injections of low molecular weight heparin, the costs of low molecular weight heparin, and really, from the beginning, an absence of proof that these injections helped prevent these complications. So going back again to the late 1990s, early 2000s, I designed a randomized controlled trial of low molecular weight heparin to prevent pregnancy complications in thrombophilic women. And the intended sample size had been 287. And, one of the reasons why I'm going back to this experience is that we didn't have the benefit of national VTE networks at the time. We didn't have the benefit of international networks of VTE networks. So we had to construct our own team. And very quickly, this trial included thrombophilic women with lab-confirmed thrombophilia, women with a placenta-mediated pregnancy complication or at high venous thrombosis risk. And the trial design is shown here. They were randomized to dalteparin 5,000 units a day for the first 20 weeks, and then 5,000 units a day, twice a day for the rest of pregnancy. And this was compared to no dalteparin. And we started the study by creating a collaborative group within Canada, one center at a time. And given the prevalence of these placenta-mediated pregnancy complications, about 5% of pregnancies end up with one of these complications. And the prevalence of the thrombophilias, about 1 in 6 of the general population will have one of the thrombophilias. We thought that this combination of a prevalent group and the prevalent thrombophilia, we'd have the study done in no time in these Canadian centers. We thought we'd be done in 2003. And fast forward to 2003, and we had recruited less than 10% of the total sample size. So we went to Australia and had some early success by recruiting through the collaboration with Bill Hague in Australia, recruiting in 4 other centers and having a grant from the CIHR to help us do this. So we thought, based on new projections or actual recruitments, that we'd be done in 2007. But this does remind me of the Churchill quote that success is not final, failure is not fatal, and it's the courage to continue that counts. And it really was persistence that got us to the very end, and I'll describe to you in a second what the very end looked like. But I think it's important to emphasize that over the time of the trial, we were told to stop at least 8 times over 12 years, largely based on the challenging recruitment. So fast forward to 2008, and with our recruitment in Canada and Australia, we still were only about halfway there. So we expanded into the UK and into the US, and this was the final team and the final number of sites. And you'll see that we required recruitment in Canada, in Australia, in the US, and the UK. And with each new country added and with each new site added, required tremendous amounts of effort to secure study drug, to obtain regulatory approval in each country, to obtain ethics approval in each site, to manage contracts, etc. And in the end, we showed that there was no difference in the composite of major VTE, severe early preeclampsia, SGA birth, or pregnancy loss between the Delta parent and the no Delta parent groups. So we concluded that antepartum Delta parent didn't prevent the collective of these complications, and that larger trials would be required to exclude smaller treatment effects, and trials of the individual complications would be required to exclude effects. And we went on very quickly just to tell you that we did do an individual patient data meta-analysis to look at the specific patient subgroups with specific placenta-mediated pregnancy complications, and with specific and with outcomes of specific prior late pregnancy-mediated complications. And this individual patient data meta-analysis really involves taking the data from each individual trial, combining it into one monster database, and then looking up subgroups and specific outcomes. And again, there was no difference in low molecular weight heparin versus no low molecular weight heparin use. So that was the world pre-networks. And now I'm going to switch gears and tell you about INVENT. And if INVENT had been in place in 1999, perhaps we would have answered this question of low molecular weight heparin use to prevent placenta-mediated pregnancy complications sooner. And we could have shortened the 15 years where low molecular weight heparin use was rampant to prevent these complications to a much shorter interval. So first, I'll tell you a little bit about the birth of INVENT. And really, INVENT was born at the suggestion of the CIHR that we do what the critical care community, global critical care community, had done with INFACT. INFACT is the International Forum for Acute Care Trialists. It includes over 50 organizations and networks that collaborate globally on clinical trials. And in fact, INFACT was the major facilitator and initiator of the REMAP-CAP study that quickly brought us many answers to therapeutic questions about COVID over a very short time interval. So they were, was in fact the inspiration. So in December of 2015, we brought together for 2 days the existing national networks, the InnoVTE network, the Australasian Society of Thrombosis and Hemostasis network, CanVector, the Canadian Venous Thromboembolism Society, or Trials Organization, I should say, the Norwegian Thrombosis Network, and the Center for Thrombosis and Hemostasis in Germany, and networks that were at their early stage of development, the Dutch Thrombosis Network, the US VTE network, and the Italian network called TRIP, along with the leadership of the ISTH. And for 2 days, we asked ourselves, what would this organization need to be useful and successful? What tools and processes, what would it require, and what metrics would we need to measure to know if we'd achieved our objectives? And the main outcome was to define these 5 aspirations for INVENT, to be the recognized international driver and accelerator of patient-oriented, investigator-initiated clinical VTE networks, be endorsed by leading scientific societies and granting agencies, be the key facilitator for international collaboration amongst VTE investigators, including networking for young investigators, be the international leader in promoting the development of new networks, that is, enhancing capacity, and identifying key unanswered questions and designing studies to answer them. This is what the organizational chart of INVENT looks like. We have a council that includes 2 members of each national network, and that council acts as our parliament, provides the board of directors that are involved in day-to-day operations, strategic direction. And we also are counseled by an external advisory board of non-academic partners and academic partners to provide suggestions for strategic direction. This is what INVENT currently looks like in terms of scope. We have 11 networks that include over 1,000 members or investigators in over 150 sites globally. And I'll let you read the list of the networks, and you can see that it really does span the north, the south, the east, and the west of the globe. So what does INVENT do? Well, we accelerate venous thrombosis trials. How do we do this? Through a study endorsement process. And that study endorsement process provides credibility to studies for grant applications and granting agencies and grant reviewers. We also, at the study endorsement stage, if we have investigators interested in the same area or the same therapeutic for the same area, we try and get them to work together. In other words, push, suggest, cajole collaboration. We provide Kickstarter and Dragon's Den grants, which are really collaborative, international collaboration seed funding. We promote the studies through our communications channels to recruit new countries to studies, to recruit sites to studies. We also have some tools that help with study conduct, including the verdict adjudication platform to help adjudicate for multiple clinical trials. We also support and encourage and develop national networks through efforts to share best practices at council meetings, to helping our national networks obtain national network grants. We've endorsed over 30 studies to date. We have biannual Kickstarter awards and annual Dragon's Den award competitions. We are very active on Twitter, or X, formerly known as Twitter, through our website, through email blasts to promote the studies that are part of the INVENT collaboration. We are involved in research standardization activities, the adjudication platform I mentioned. We also have a very vibrant global thrombosis research seminar series where we discuss one of the endorsed studies and at least one methodological question or innovation that is part of that study. And we also, in partnership with ISTH, support fellowships. And these fellowships are for future trialists or early career stage trialists to travel to an established site within one of the INVENT member networks, and we provide accommodation and living expenses for up to 2 months. We have funded in 3 years 7 fellowships that involve 6 of our network member countries. Just to highlight a few of the successes of the INVENT machine. One is for the COBRA study, which is a comparison of bleeding risk between rivaroxaban and apixaban for the treatment of acute VTE. Our INVENT facilitated a collaboration between the Canadian investigators where the study had begun and Australian investigators that led to a grant in Australia of $1 million to expand recruitment to Australia. And COBRA is now at more than 2,300 of 2,700 recruited studies. The Adjust DVT study similarly provided Kickstarter support to allow expansion of the study to another country and they completed recruitment. The ADJUST-DVT study looks at age-adjusted D-dimer cutoffs to rule out deep vein thrombosis. The SAVOR study is a randomized controlled trial of rosuvastatin versus placebo to see whether it, as adjuvant treatment, reduces the risk of recurrent venous thrombosis. And Kickstarter and Dragon's Den funding allowed expansion to Europe with the NOVTE partners getting a French PHRC grant for recruitment in France and over $1 million. Given today's focus on women's studies, I'll just mention a few other recruiting studies. They include the LEAD study, which was mentioned by a prior speaker, that is exploring whether we can safely rule out deep vein thrombosis with the left clinical decision rule and D-dimer, and 300 of 366 patients have been recruited in 3 member countries. The pilot PARTM study mentioned by Dr. Blondon in the first talk has completed recruitment, and the manuscript is in preparation, along with preparation for the larger definitive aspirin to prevent postpartum thrombosis trial. The PrEP and Go study is another study that Dr. Skeith is leading, and recently published studies are on the right-hand part of the slide, and the ones that are in the women's health area include the ALIFE study and the high-low studies. And this, again, is just to highlight the PrEP and Go study received some Kickstarter funding to expand to Dr. Buchmaller's site in Saint-Étienne in France to lead development of the study in France. And of course, the high, low, and ALIFE studies, which were very important seminal research that was published in the Lancet in the last few years, defining the dose required for thromboprophylaxis in women with prior VTE, and once again showing that in thrombophilic women with recurrent miscarriage and inherited thrombophilia, low molecular weight heparin is a burden and of no benefit. So just very briefly, I'm going to conclude with a brief introduction of what we think is the future. The next phase of development of INVENT is the development of clinical trials platform, much like REMAP-CAP did for COVID. We're hoping Converge does for VTE management. And this is Converge is a clinical trials platform for international VTE research integration. So as I've hopefully described, conducting international trials is not for the faint of heart. One must find collaborators to agree on a study design, develop a protocol, get funding, get regulatory approval in each participating country, get research ethics approval in each site, negotiate a study agreement, contract with each site, and then with your next study, start all over again from scratch. So with an integrated clinical trials platform, we're hoping that will shorten the time that trials take to get up and running. This would involve developing shared master protocols in the VTE space, and then adding amendments for each new experimental intervention or sub-protocol. So once the master protocol is agreed upon by the community, obtains regulatory approval in each country, obtains REB approval in each site, and has master research contract approval in each site, new trials can be added as amendments for quick, efficient scientific, regulatory, research ethics, and contract approval. With the international network that we have with INVENT and good data governance policies and procedures, high quality clinical trials can be generated. The first of these is going to be an umbrella trial for acute VTE, and an umbrella trial looks at multiple interventions for a single disease entity. And I'll just use 3 recently endorsed studies as examples of what this might look like after we built it. So patients with acute VTE would be included. We would have predefined subgroups eligible to receive one or more of the interventions as an amendment to the protocol. So, for example, the RADIANT study, which is exploring the use of omeprazole versus placebo to reduce major and clinically relevant non-major bleeding, would explore this in a subgroup of patients with any VTE that had a plan for more than 3 months of treatment and patients that were over 65. The CONQUER study, which is looking at colchicine compared to placebo for prevention of recurrent VTE and post-thrombotic syndrome, would include any patient with acute leg DVT. And the BAT study, which is exploring in acute VTE patients that have antiplatelet indications, anticoagulants alone versus anticoagulants plus aspirin. So one can imagine that all of 3 of these trials could efficiently be started up once the shared master protocol goes through all of the approvals just through an amendment process. So I'm going to conclude probably with the most important slide. If you are part of a network doing venous thrombosis trials, consider joining INVENT. If you're in the early stages of thinking about a network, please reach out. We're happy to help you establish your network. And finally, if you're just interested in following us and following the developments of the network, we encourage you to follow us on X and visit our website and or join as a professional member to get on our email blast list. And I'd like to conclude by acknowledging the unrestricted grant support that we obtain from our partners listed here on the slide. Thank you.
Wow, Professor Rodger, thank you. It is always an absolute privilege to hear the journey that your leadership has made possible. It's absolutely staggering and extremely exciting to see the next phase of this journey, the next chapter in the platform trials. Is there a plan to consider such a platform approach to any of the questions that we discussed today in terms of women's health, Professor Rodger?
Yes, I'm clearly biased, but yes, I would love to see us develop, for example, a postpartum VTE prevention platform and other platforms for diagnosis of VTE and in pregnancy. But we're starting with acute VTE and building, acute VTE with a common condition of acute VTE and sort of building from. Yeah.
And it would be incredible to see that journey come full circle. You described the pain and the resilience that is involved in conducting a really excellent multi-center trial in your experience with the TIP study. I am so glad that at no point during those 8 times you were advised to stop that you didn't. I will never forget the sense of relief and gratitude amongst all the community who probably didn't even know you and the team at the time. What you achieved on behalf of our patients in terms of avoiding the use of pneumocort heparin and in terms of immediate impact on national and international guidelines was staggering. So thank you. And what if we could achieve the same for over-liberal use of postpartum VTE prevention? I'm just keeping, and I don't think there are any open questions in the Q&A, but can I ask a question that I don't know the answer to at all, Prof. Rodger? Are there any political developments internationally in terms of enhancing the plans that Invent VT have to move forward with this effective, efficient platform approach? How can we do better in terms of our efficiency of energy use?
Yeah, no, I'd say that's an excellent question, comment, and as part of the G7 communique, I think it was 2 or 3 years ago, the G7 country leaders did affirm the need to develop better international collaboration in clinical trials and clinical trial research, really in all areas.
Okay.
And you know, COVID certainly was the example par excellence that you know, a lot can be achieved with the right structure, with the right collaboration, and goodwill across countries. And we'd love to see that in the VTE space.
Thank you. Goodwill is a lovely comment on which to finish, and huge congratulations as well to the UK network under the leadership of Dr. Roberts. Huge goodwill. So thank you, thank you, Professor Rodger, and thank you to all of our phenomenal speakers today. I'd invite you all to turn back on your cameras if you're still with us. It's been a privilege and a joy to listen to you all. Thank you all for being with us. Thank you to our great audience for their brilliant comments and questions and for making this a lively discussion. And above all, thank you, Joe, and to Professor Hunt, for all that you do personally, Joe, on behalf of the thrombosis community. You inspire us and make us do better every single day. So wishing you and everybody a very, very happy World Thrombosis Day on Friday. And just to remind everybody that the accredited recording of this session will be available on the platform within 24 hours. I'll hand over to Joe for the final words. Thank you.